Hello everybody, and welcome to this presentation on acute GI bleed in a patient with metabolic syndrome, presented by Julia Yuan and Jessica Chen, MD, at the UC San Diego School of Medicine. Non-alcoholic steatohepatitis, also known as NASH, is a subset of non-alcoholic fatty liver disease, or NAFLD, and is marked by progressive hepatic inflammation with potential development of cirrhosis. NASH is typically asymptomatic but can present as fatigue and abdominal pain, accompanied by elevated AST and ALT, and is more likely to occur in patients with metabolic syndrome. Cirrhosis is often asymptomatic, but clinical exam may reveal jaundice, spider angiomas, gynecomastia, or asterixis. NAFLD-related cirrhosis is an established but underappreciated risk factor for hepatocellular carcinoma, and NAFLD-related HCC incidence is rising in the U.S. population. Our learning objectives are to recognize clinical symptomatic progression from NASH to HCC, improve screening, surveillance, and intervention protocols for high-risk NASH patients, and to apply the new 2020 guidelines by the American Gastroenterology Association for NAFLD and NASH patients in daily primary care practice. Our patient is a 68-year-old male with a past medical history of hypertension, hyperlipidemia, obesity, fatty liver, and type 2 diabetes mellitus. He presented with 1 month of fatigue, shortness of breath, nausea, decreased appetite, hematochezia, and weight loss. Physical exam showed pallor, lower extremity edema, and extensive spider angiomas, and labs showed a hemoglobin of 4.4 and a hematocrit of 14.8. The patient was then referred to the emergency department. At the emergency department, an upper endoscopy revealed multiple large esophageal varices, and hepatomegaly and cirrhosis were observed on ultrasound. He also received 5 units of packed red blood cells. The patient returned for multiple follow-ups. His labs showed improved hematocrit and hemoglobin, but he demonstrated continued weight loss and fatigue disproportionate to recovery. Ultimately, a CT revealed metastatic stage 4B hepatocellular carcinoma. This is the time course for our patient. On day 1, he presented with fatigue, nausea, hematochezia, low hemoglobin, and hematocrit, and was referred to the ED and liver clinic. He returned for follow-up on days 6, 20, 34, and 48 with improved hemoglobin and hematocrit, but persistent fatigue and weight loss. On day 57, CT showed metastatic stage 4B HCC. In addition to routine labs and physical exam, updated 2020 guidelines by the American Gastroenterology Association recommend that all NAFLD patients receive non-invasive cirrhosis screening through at least 2 of the following: point-of-care tests, specialized blood tests, and imaging. For NAFLD patients with detected cirrhosis or advanced fibrosis, the AGA recommends HCC surveillance through regular ultrasound every 6 months, usually with alpha-fetoprotein. The FIB-4 score is a point-of-care test that uses patient age, platelet count, AST, and ALT to calculate the risk of advanced fibrosis and cirrhosis. A score under 1.3 is low risk for advanced fibrosis with a negative predictive value of over 90%. Scores above 2.67 have a positive predictive value of 80% for advanced fibrosis. Ideally, scores above 1.3 should be referred out for further evaluation. Specialized blood tests include the Enhanced Liver Fibrosis, or ELF panel, which utilizes hyaluronic acid, procollagen 3 aminopeptide, and tissue inhibitor of metalloproteinase 1. A score of over 10.5 is likely to indicate advanced fibrosis or cirrhosis, with a sensitivity of 79% and specificity of 91%. Imaging options include FibroScan transient elastography, which uses both ultrasound and low-frequency elastic waves to quantify liver fibrosis. It has 85% sensitivity and 82% specificity for diagnosing advanced fibrosis, and a 92% sensitivity and specificity for diagnosing cirrhosis. Unfortunately, ELF panel isn't readily available for clinical use in the US, and FibroScan isn't accessible for most primary care providers. But FIB-4 can be calculated using age, platelet count, AST, and ALT, all of which are very commonly tested and easily available values. It would be especially convenient for PCPs to conduct yearly FIB-4 scoring if it were included as a risk prediction model SmartLink in Epic and other electronic medical records, similar to the .ASCVD risk calculator for atherosclerotic cardiovascular disease. And again, FIB-4 scores greater than 1.3, and especially those above 2.67, should be referred to hepatology for further imaging and evaluation of fibrosis and cirrhosis. This is a graph of our patient's lab values from 2004 to 2020, when he was referred to the ED. ALT is shown in orange, AST in red, and platelet count in blue. As you can see, his AST and ALT values began declining in 2012, which was at the time attributed to his reduced alcohol consumption and weight loss. Platelet count also declined, but was attributed to long-term alcohol consumption. And this is a clear example of the paradoxical decrease in liver enzymes that can occur with cirrhosis, which can be falsely reassuring, especially when it happens in conjunction with lifestyle changes. However, when we use those same AST, ALT, and platelet values to calculate our patient's FIB-4 scores, we can see that he actually passes the 2.67 cutoff around that time in 2012, indicating a high likelihood of advanced fibrosis. And so this really highlights the utility of FIB-4 scoring in monitoring NASH patients and when to refer them for specialist care. In terms of management, lifestyle modifications are generally the first step. This includes abstinence from alcohol and smoking cessation, as well as vaccination for hepatitis A and B if not previously completed. Weight loss is also shown to improve hepatic steatosis, and the rate of weight loss is ideally a 7% to 10% reduction over a 1-year period. For patients who are unable to lose weight through diet, exercise, or behavioral modification, bariatric surgery can also help decrease steatosis, inflammation, fibrosis, and lower the risk of cirrhosis. However, this is limited to patients without decompensated cirrhosis, and some studies have shown worsening fibrosis in the post-op period. And it's important to mention that it's currently unclear whether weight loss has a significant effect on HCC risk. There are currently no FDA-approved drugs for NAFLD or NASH treatment. However, a number of medications have shown some promise. Metformin is first line for type 2 diabetes, and while it hasn't been shown to improve liver histology, it is associated with decreased HCC risk in diabetic patients with and without viral hepatitis, although it remains to be seen if this holds true in NAFLD and NASH patients as well. Pioglitazone has also been shown in trials to improve steatosis, inflammation, fibrosis, and hepatocyte ballooning in NASH, although its side effect of weight gain can limit its clinical utility and should therefore be carefully reviewed before switching patients over. Liraglutide, a GLP-1 receptor agonist, has been very promising in phase 2 trials at reducing hepatic steatosis and aiding in weight loss in diabetic NAFLD patients, and can therefore be an appropriate option for those with concurrent diabetes. Another treatment that has shown promise is high-dose vitamin E, 800 international units a day, which has been associated with higher rates of improvement in NASH, reduced liver enzymes, and reduced inflammation and steatosis in non-diabetic, non-cirrhotic NASH patients. Observational data has also shown improvement in diabetic and cirrhotic patients as well. However, this is currently only used in patients with biopsy-proven NASH, since high-dose vitamin E is associated with slightly increased mortality and a slight increased risk of hemorrhagic stroke and prostate cancer. Biopsy is the gold standard for NASH diagnosis, but due to procedure invasiveness, cost, and low HCC risk for non-cirrhotic NAFLD and NASH, biopsy is infrequently pursued in primary care. This NASH patient was asymptomatic until a significant GI bleed, with a hemoglobin of 4.4, hematocrit of 14.8, and cirrhosis weeks prior to eventual stage 4B hepatocellular carcinoma diagnosis. He is a candidate for the new AGA guidelines on NAFLD-related HCC surveillance. Early HCC detection is critical in treatment, and increased emphasis on NAFLD and NASH screening and surveillance may have been instrumental in his prognosis. Additionally, streamlining risk prediction scoring tools in electronic medical records may increase monitoring for NAFLD and NASH patients. In conclusion, we should recognize the importance of increased HCC surveillance in high-risk NAFLD and NASH patients with metabolic syndrome, and recognize the updated protocols for cirrhosis and hepatocellular carcinoma screening and surveillance in NAFLD and NASH patients using new 2020 HEA guidelines. Especially relevant for primary care providers is the point that annual FIB-4 scoring of NAFLD and NASH patients can improve screening and risk stratification for advanced fibrosis and cirrhosis. These are my references, and thank you for listening.